So we're talking about the SUMMIT trial, which was a hypothesis-generating basket trial that started several years ago, where we tried to investigate if patients whose tumors harbor ERBB2 mutations would benefit from Neratinib single-agent therapy. Now, what we presented at the San Antonio breast cancer meeting was the breast cancer cohorts from this study. And the breast cancer cohorts really have evolved during the duration of this trial, such that when we studied single-agent Neratinib for hormone receptor-positive, HER2-non-amplified, HER2-mutated metastatic breast cancer, single-agent overall response rates were about 15%, with a median progression-free survival of about 3.6 months. Single-agent Neratinib for HER2-mutated metastatic triple-negative breast cancer yielded about 20% response rate and a progression-free survival of 2 months. We then, within SUMMIT, added fulvestrant to Neratinib to overcome the detrimental impact of the HER2 crosstalk. And with that, there was an improvement in overall response rate to 30%, and the median progression-free survival was 5.4 months. Of particular note, about 37% or 14 patients in this cohort had received prior CDK4/6 inhibitor. What we then learned was that when we looked at paired tumor biopsies and pre and post plasma samples, we noticed that there was an acquisition of one or more new HER2 mutation and or amplification of the mutant allele. And aside from this HER2 amplification and on-target signaling, there was no other broad pattern. Additionally, our preclinical data suggested that the combination of Neratinib plus trastuzumab was more efficacious than either agent alone. So taking all of this into account, we therefore investigated if dual HER2 targeted therapy with the addition of trastuzumab to Neratinib containing regimens would be more effective. And specifically for our hormone receptor positive HER2 non-amplified HER2 mutated cohort, we wanted to investigate the contribution of Neratinib to such a combination strategy. We therefore enrolled a small randomized Simon two-stage comparison of 7 patients each, such that patients either receive the triplet of Neratinib, trastuzumab, fulvestrant, the doublet of fulvestrant plus trastuzumab, or fulvestrant alone. Now, the non-Neratinib containing regimens were allowed to cross over upon clinical progression to receive the triplet. And we also made sure that all these patients who received triplet in the SUMMIT cohort had progressed on prior CDK4/6 inhibitor therapy to reflect upon the current standard of care. And with such an approach, what we noticed was when we looked at the combined non-randomized triplet patients and the randomized 7 patients in the current randomized cohort of the triplet strategy, of the total 33 patients that were treated with this triplet, the overall response rate was 46%, and the median progression-free survival was 7 months. When we looked at our metastatic triple-negative breast cancer cohort, which then were treated with a combination of Neratinib plus trastuzumab, of these 18 patients, the overall response rate was 33%, and the median progression-free survival here was 6 months. So these were very exciting results for us. So when we looked at, just to put the triplet data for our hormone receptor positive cohort into context, we know that these HER2 mutations can be prognostic. We know that about 2 to 12% of solid tumors have HER2 mutations, but they're enriched in metastatic lobular cancers. About 15% of our lobular cancers have these HER2 mutations. These were exciting data because this is an oncogenic driver. And so an overall response rate despite prior CDK4/6 inhibitor therapy in this patient population with median of 5 prior lines of therapy was actually a very good efficacy signal. What we did see was that diarrhea rates were higher than anticipated for the triplet regimen. Grade 3 diarrhea in this cohort of hormone receptor positive that received the triplet was 46%. And this was despite the loperamide prophylaxis. So as a future impact, we want to make sure that patients are compliant with antidiarrheal medications and they are being managed very appropriately for supportive management. And in addition, we're also going to try and incorporate the dose escalation, which is now part of the US package insert based on the control trial. So we're hoping that that would really further improve and have a further impact. And we'll continue to enroll to this cohort. We've actually enrolled a total of 50 patients, the safety and efficacy of whom will be analyzed. For the triple-negative breast cancer cohort, the diarrhea rate was 17%, grade 3 diarrhea, and we'll continue to enroll to this cohort as well to further understand the efficacy in this patient population that had received a median of prior 3.5 prior lines of therapy. So again, very impressive results for this, just attesting to the fact that these are oncogenic mutations and that Neratinib certainly is sensitive for these mutations.